So this is kind of going back into the intermediate risk. I know a lot of patients are kind of like, is there a way that we could get more aggressive treatment in an intermediate risk category so it doesn't, progress? So for intermediate risk, would it make sense if somebody is on Lupron to automatically start a second generation hormone therapy?
We don't really know. Intermediate risk patients have excellent cure rates with what we're already doing. And so to improve on those outcomes is quite difficult since there's not a lot of room for improvement. It's already an excellent cure rate. The argument in favor of using medicines like that is that they are well tolerated. They're expensive sometimes, and of course, it would be difficult to get insurance coverage for them. So I think treatment for intermediate risk is going the other direction. As the radiation therapies are getting so much better, there's more and more discussion about skipping the hormone therapy altogether, especially now that we have these new PSMA PET scans that can confirm the absence of any metastatic spread. It is feasible to give second-generation agents to intermediate risk, but I don't think there's a lot of push to do that.
So in regards to these second-generation hormone therapies, we have Xtandi enzalutamide, Erleada apalutamide, Nubeqa darolutamide. Are there any studies evaluating the use of these in like those unfavorable high-risk categories?
Well, there is for Zytiga in I mentioned before, the Stampede trial. And the general assumption is that these second-generation hormonal agents have about the same amount of anti-cancer horsepower and that they can be used interchangeably. So usually selection is based more upon what insurance will pay for or possibly minimizing side effects. The side effects of these medicines are not that prominent, but they do have a slightly different profile.
What would you say the difference in the outcome would be between a patient who would add chemotherapy or second-generation hormone therapy versus somebody who wouldn't do it?
Well, I think that if you're looking at an unfavorable high-risk patient, you could improve your cure rates 10 to 15 to 20%, and the studies do show better survival. So it's a very meaningful addition to the way we treat these people.
So per Dr. Tanya Dorf's study, she's with City of Hope, she did a study with hormone therapy, high-risk men who had radical prostatectomies. And the question is, should men with high-risk disease who decide to have a radical prostatectomy consider hormone therapy? And if so, for how long?
I think they should. The concern with doing radical prostatectomy in high risk is that the vast majority of these people are going to have the cancer come back. They won't be able to get it all out. And in her study, which was published in the Journal of Clinical Oncology, they showed almost 90% 5-year disease-free survival in men that took a year's worth of hormone treatment after the operation. So compared to relapse rates that are almost 50% or higher for high-risk disease, to have a 5-year disease-free survival of 90% with the use of Lupron right after surgery seems to make a lot of sense.
Would you say the same for, I guess, high intermediate risk as well, who have radical prostatectomy?
One of the things, of course, aren't a whole lot of advantages to surgery anymore, but one advantage is that they have the information after the operation as to whether the disease is completely organ confined. And then, of course, they can do genetic testing on these samples now with things like Decipher and actually provide the patient with a percentage likelihood that they will stay cured. And if it's an unhappy number, let's say they tell the patient there's a 40% chance this is coming back in the next 5 years, those patients may be very interested in taking some hormone treatment to try and improve on those numbers.
The next question is, how will the recent PSMA approval affect high-risk prostate cancer patients?
Oh, wow. We don't know for sure. This is a very powerful new imaging technology that answers the question that we've always struggled to answer, which is, how has the cancer spread outside the gland? And PSMA PET scans are not 100% accurate. It is possible to have cancer spread outside it in very small amounts that could be missed by the scan, but substantial amounts of cancer are going to be rarely missed. And this may allow us to back off in some of the intense therapy that we've been discussing. So the idea of Taxotere and second-generation hormonal agents is a precaution against the possibility that there's some metastatic disease out there that was missed on the standard bone scans and the CAT scans. If we have a PSMA PET scan that shows that everything's all clear, that everything is confined inside the prostate, might that allow us to skip or reduce the amount of hormone treatment or chemotherapy? People are going to be talking about that because these hormone treatments and chemo treatments have quite a few side effects.
Thanks so much for watching. If you would like more information on any copay programs or financial assistance when it comes to these second-generation hormone therapies, you can visit our website at PCRI.org and also contact our helpline. There's many programs out there that can help you pay for these somewhat expensive drugs. Also, if you would like more information on anything that we discussed today, you can visit our website at PCRI.org and also subscribe to our YouTube channel. We come out with new prostate cancer videos every week.